Welcome to Thinking in Psychiatry, an Academy by Psychiatry podcast, where we distill new research, translate evidence into practice, and support clinical decision-making for busy clinicians. I'm Dr. Sanil Rege, consultant psychiatrist and content curator at the Academy by Psychiatry. Today, I'm walking you through a 2025 personal view in the Lancet Psychiatry, an article published called Psychotic Symptoms During Pharmacological Management of ADHD, Clinical Considerations and Research Needs. This is an article published by Cortese and colleagues, and it deals with a scenario most of us have either faced or will face. A patient on ADHD medication reports paranoia, unusual beliefs, perceptual changes, sometimes subtle, sometimes clearly psychotic. The family panics, the clinician panics, and the reflex is often dichotomous, binary, stop the stimulant, it caused psychosis. But the real question is a bit more complex, a bit more nuanced. And what we're looking to do is to make it more clinically useful. The question is, when psychosis appears in someone with ADHD on medication, how much is the drug and how much is the underlying vulnerability that was already there? And then practically, what do we do next without undertreating ADHD or missing emerging psychosis? So this paper is trying to give us a framework, not necessarily a guideline. So let's start off looking at what kind of paper is this. This isn't a single trial, it's a synthesis and clinical framework paper. So the authors pulled together epidemiology linking ADHD to later psychotic disorders, pharmacoepidemiology from large cohorts, countries like Hong Kong, Sweden, Iceland, and others. They have causal inference design, like within individual comparisons and target trial emulation, and then the clinical high-risk literature. And they use tools, as we see later, the high-risk mental state and the self-report screens such as PQ-16. The value here in this paper is really about how the evidence is organized into risk assessment, screening, monitoring, and then response, which makes it very relevant to clinical practice. So let me take you through this. One of the most important points in this paper is the baseline risk. A meta-analysis of cohort and case control studies, close to 2 million people, finds that ADHD diagnosed before the age of 18 is associated with a markedly higher risk of later psychotic disorder. So when psychosis emerges in someone being treated for ADHD, we can't simply say the medication caused the psychosis in an otherwise low-risk person. The question is, why might ADHD link to psychosis vulnerability? And the paper lays out several plausible hypotheses. And clinically, they'll all feel familiar. So they talk about shared genetic and environmental vulnerabilities, prenatal and perinatal risks, overlap with bipolar spectrum disorders, higher downstream risk of substance use disorders, especially cannabis, and that early attentional and executive dysfunction may be part of a prodromal trajectory, a prodromal psychosis that can be mislabeled as ADHD. So the first clinical shift for all of us is, when psychotic symptoms emerge, it's important that we don't only ask, what drug did we prescribe, but rather, what vulnerability did we miss or underestimate? This is really thinking about the reverse causality aspect. The second domain covered in the paper is psychotic symptoms during treatment are uncommon, but not rare. So here's the question of frequency. Across observational and interventional studies, the paper summarizes that a small minority of stimulant-treated patients develop psychotic symptoms during treatment. Uncommon, but clinically relevant. The practical takeaway for us isn't to be frightened from prescribing, but it's to normalize that over a career, especially if we treat ADHD at scale, we're likely to see it, which means what we need is not fear, but rather a framework to monitor, to intervene early. The third important domain from the paper: do different ADHD medications differ in psychosis risk? So the paper reviews comparative pharmacoepidemiology, suggesting a signal that amphetamines may be associated with higher rates of psychotic events than methylphenidate, while atomoxetine does not show an increased risk compared with methylphenidate in some data sets. But the authors repeatedly emphasize the key caveat, confounding by indication. And what that means is more severe ADHD may be more likely to be treated with amphetamines, and severity itself may track higher psychosis vulnerability through comorbidity, substance use, sleep disruption, trauma exposure, and social adversity. So we're looking at confounding factors playing a part and what's known as a protopathic bias, where it's not the medication as the only cause, but rather a number of other factors playing a part as well. So what's the responsible stance for us to take? Treat the amphetamine signal as a risk hypothesis, not definitive proof. But when we're uncertain, it's important that we choose the path with the lower theoretical and observational signal, especially in high-risk profiles. So thinking about non-stimulants and methylphenidate over amphetamine is something we should put right up as part of the strategy. So the fourth domain, do stimulants cause psychosis? And this is where the paper becomes clinically very relevant. So simple comparisons, ADHD medication users versus the general population can dramatically overestimate drug risk because the comparison group includes people without ADHD. The more informative designs are within individual approaches. So comparing medicated versus unmedicated periods in the same person. So in large cohorts of young people treated with methylphenidate, these designs generally show no meaningful increase in psychotic events during medicated periods compared with unmedicated periods. In fact, some data show increased risk in the pre-exposure window, again pointing to baseline vulnerability rather than medication as the driver. So a fair summary is that for methylphenidate, current evidence does not support a strong causal psychosis signal at the population level. That, of course, does not mean that psychosis never occurs. It means we should be careful about attributing causation. So let's now move towards mechanism. The paper discusses mechanisms, keeps it brief, but clinically it helps us and also helps us in making choices. Now we know both methylphenidate and amphetamines increase catecholamine signaling, dopamine and noradrenaline, through different pharmacological routes. So we know that methylphenidate through DAT and NAT reuptake inhibition, but dexamphetamine is different here because it also releases dopamine. So milligram for milligram, dexamphetamine is more potent, but the clinical response might be different at different individual levels. In most individuals, this catecholamine-enhanced signaling improves attention and executive function. But in a smaller subgroup with genetic, developmental, or substance-related vulnerability, even modest shifts in dopaminergic signaling, particularly striatal dopamine, may lower the threshold for positive symptoms. And in the Academy course on schizophrenia, where the neurobiology of schizophrenia has been covered, we know that this associative striatum plays an important part in the pathogenesis of psychotic symptoms. So the important thing is for us to think in spectra. One, we have a large group with very low risk, even with stimulants. Two, we have a smaller group where vulnerability is high enough that treatment becomes a trigger or amplifier, which leads directly to what the paper argues is missing from many guidelines, screening. So in my opinion, the paper's most useful contribution is this preventative framework, a move from reactive binary thinking to risk-guided prescribing. So what they propose is a stepwise screening pathway for psychosis vulnerability applied during ADHD assessment, not only after something goes wrong. So step one, family history. Start with a simple question. We don't always ask systematically, is there a family history of psychosis? And sometimes it might be helpful to outline the specific symptoms because they might not say a family history of psychosis, but they might talk about bizarre behavior or suspiciousness or extreme paranoia, etc. If yes, the paper recommends more structured assessment of clinical high-risk state. Step two, a rapid screen for psychosis-like experiences. So here, for those without obvious familial risk, use brief self-report tools such as PQ16 and Prime Screen. These are fast, scalable, and act as triage tools. Step 3, the use of CARMS, which is CAARMS, stands for Comprehensive Assessment of At-Risk Mental State. So they recommend CARMS for those above threshold or higher risk. They talk about only those screening positive proceed to CARMS. That stepwise model matters because it enriches risk detection without overwhelming services, and crucially changes how we counsel. So a negative structured assessment supports routine ADHD treatment and reassures us. A positive assessment identifies a small subgroup where we prescribe with a lot more caution, monitor closely, involve family members, ensure collateral information is obtained, which we of course do at all levels, and prioritize psychosocial and needs-based interventions. And this paper is also careful about communication. So at-risk mental state needs to be conveyed sensitively with co-developed resources, so leaflets, etc., not as a stigmatizing label. The paper then moves to the practicality of treatment. The question is, if psychotic symptoms occur anyway, what then? So even with screening, some cases will occur. So the paper distinguishes between psychosis in the context of amphetamine misuse with higher risk of persistence versus psychotic symptoms emerging during prescribed ADHD treatment, more often transient. One practical point clinicians will appreciate is that regulatory data suggests that in most cases, psychotic symptoms resolve after stopping the stimulant, often without needing antipsychotics. Then comes the more contentious question, rechallenge. The authors suggest cautiously that if a rechallenge is considered, methylphenidate may be the safer option than amphetamines, whilst acknowledging confounding in the comparative evidence. They also highlight non-stimulant options. So we have atomoxetine, alpha-2 agonist, guanfacine, clonidine, particularly helpful for hyperactivity and impulsivity, viloxazine, depending on jurisdiction and availability, and for CARMS positive individuals, so where the comprehensive assessment of at-risk mental states shows that these individuals may be at risk, alpha-2 agonists are proposed as a rational first-line strategy, again, framed as an evidence-informed stance rather than proven superiority. And they explicitly advise against prophylactic routine use of low-dose antipsychotics alongside stimulants in high-risk states. And that remains a research question. They may be useful, but they advise against routine use of prophylactic low-dose antipsychotics. The next question is dosing. And this is where risk creeps in. The paper makes an important point about dose, particularly with amphetamines. Higher amphetamine doses appear associated with higher odds of hospitalization for psychosis or mania in case control studies. It's not definitive, but it's consistent with what we expect pharmacodynamically. Higher doses can drive more phasic dopamine signaling. And of course, with immediate release formulations, phasic dopamine signaling is enhanced. So they don't necessarily call for rigid dose ceilings, but they do propose a sensible hierarchy. Assess baseline psychotic-like symptoms, titrate carefully, and consider switching class or adding an alpha-2 agonist before going above licensed maximum. And reserve supra-licensed doses for situations where the risk-benefit balance is clearly favorable and monitored. So that's really a practical way to keep clinical flexibility without us drifting into avoidable risk. At this point, I do want to bring in a 2025 Icelandic study titled Risk of Hospitalization for First Onset Psychosis or Mania Within a Year of ADHD Medication Initiation in Adults with ADHD. So what this study showed is that for adults for up to a year following the first treatment with methylphenidate, amphetamines, or atomoxetine, there is a small but clinically relevant risk of developing a first onset psychotic episode or mania severe enough to require admission. In 8 to 9 cases out of 10, the admission might have been avoided were it not for the use of ADHD medicines. So this is the attributable fraction. In Iceland, around 2/3 of those admitted are re-prescribed ADHD drugs within a year. And for those, 1 in 4 is readmitted within a year. So I think this adds some extra nuance, and we've got to think about this re-challenge within that context, because 1 in 4 is readmitted and they are re-challenged with ADHD medications within that year. So something for us to think about. I'll briefly touch on limitations. So the key is that most of this evidence is observational and residual confounding remains. So therefore, the paper is calling for better quantification of psychosis risk in ADHD, independent of medication, and prospective cohorts that include baseline psychosis risk screening, those that follow people longitudinally. So let me bring all of this together and provide some clinical pearls and some takeaways. So the first clinical pearl is that ADHD, especially when diagnosed in childhood, carries a substantially elevated baseline risk of later psychotic disorder, independently. If psychosis emerges, it's important that we don't assume the stimulant is the whole story. Pearl 2. Psychotic symptoms during stimulant treatment are uncommon, but clinically relevant and real. They're usually transient, often resolving with stimulant discontinuation. Pearl 3. For methylphenidate, current evidence does not support a strong causal link with psychosis at the population level. The apparent risk in simple comparisons is often confounding by indication. Pearl 4. A stepwise screening pathway. Family history, brief screens like PQ16, prime screen, and CARMS, the comprehensive assessment of at-risk mental state, where indicated, can identify the small subgroup needing closer monitoring and more cautious pharmacological nuanced prescribing. The takeaways from a decision-making perspective is to move from a reactive stance of wait for psychosis and then stop everything to a more proactive, risk-guided approach. Screen for vulnerability, choose and dose thoughtfully, monitor carefully, and deliver the substantial benefits of ADHD pharmacotherapy wherever possible. Thanks for listening. You can find links to the paper and related Academy modules on your dashboard. I'm Dr. Sanil Rege, and this is Thinking in Psychiatry, where how we think is just as important as what we prescribe. Until next time, keep thinking carefully and keep thinking clinically. Bye-bye.